to make a comparison between the nerve supply of the parietal pericardium and the nerve supply of the visceral pericardium and the nerve supply of the carotid bodies and the baroreceptors in the aortic arch. I repeat this. It's a long sentence, but I repeat it. The whole exercise from studying the cardiac plexus is to compare the nerve supply of the parietal pericardium, which is, you are expected to know it because we studied it earlier in a lab called innervation of the pericardium, in which we studied the phrenic nerve, and we called it the phrenic nerve, and in which we said the phrenic nerve is a somatic nerve, not autonomic nerve, derived mainly from C4, and because it is somatic, the pain which is going to be conveyed by the phrenic from the parietal pericardium and the parietal pleura, namely the mediastinal parietal pleura, will be somatic pain, and somatic pain is usually well defined and well described. You agree?
Yes.
And because it is phrenic nerve or phrenic nerve, the referred pain of the phrenic will be over the shoulders, whether right or left. You agree? Conversely, yani on the opposite side, the pain mediated or conveyed by the autonomic system carrying the pain impulse from visceral pericardium will be ill-defined and ill-localized. Is it conveyed by phrenic? No. Is it conveyed by the other one which was beside it or behind it called vagus? No. With which system then is it conveyed? It's conveyed by sympathetic. So the pain of a myocardial ischemia, ischemia means less blood reaching the muscle of the heart. When a muscle is ischemic, the blood reaching it is less than normal, but still it is alive. You know that. And when we say myocardial infarction, it's dead. In both, we have pain. And in both, the pain will irritate the visceral pericardium. And we can actually convey the pain of the visceral pericardium, even the myocardium, by sympathetic and not vagus nor phrenic. So, which system of the nervous system is going to convey the ill-defined, the ill-localized pain of the heart? The sympathetic. This is the whole aim from this game. Last year, there was a very simple exam. I mean, it's a very simple question. I remember it like this. cardiac pain due to myocardial ischemia or myocardial infarction. Of course, when you read something like this, it makes you, oh, what's all of that? Is conveyed by phrenic, vagus, cardiac plexus, and two silly things, glossopharyngeal or whatever. What's here the answer? Cardiac plexus. You see how easy now? Because in the cardiac plexus, although I have vagus, but also I have sympathetic. You agree? So what's the aim of the whole exercise? To know that phrenic, or to confirm to ourselves. This is the first time you read phrenic. We need you to know that phrenic is phorenic. Phrenic is phorenic, somatic, and the pain is somatic, and it is well defined, it is well described. We need you to know this. And this is really a lot. This is a lot to know, because it will help you immediately to recognize a case of pericarditis. If the patient comes and he is here, and he's pinpointing, yeah, it can be this, it can be that. But if it is well defined, well localized, and going over the shoulder, for sure, this is pericarditis. Visceral or parietal. But if it is vague and going to C8 and T1 and T2 and T3, this is the other one, which is the visceral pericardium or the ill-defined pain, which is mediated by sympathetic. Nowadays, when they are having hopeless case, they cannot treat by any modality in cardiac pain due to myocardial ischemia, they go to the sympathetic and destroy it, so the patient will not feel the pain and let him die in peace. They do it. It's a modality of treatment. It is. I have a father of one of my previous students, and her father died this way. He was over 100 cigarettes a day, but this was the modality of treatment he received until he died. Kill the sympathetic. Are we going to kill the vagus for this? No. Vagus nowadays, they put in it some electrodes to treat epilepsy, to prevent Alzheimer. This is another scope. So I have to know what vagus is doing, what the sympathetic is doing, what phrenic is doing. This is the aim of the whole exercise. Don't complicate it. It is very simple. This, I start with it and I end with it. Here is the curved cardiac plexus. And the curved cardiac plexus is fitting into the curved aorta or aortic arch. Curved aorta, curved aortic, a curved cardiac plexus. A curve and a curve. Aortic arch, whenever I hear it, it makes my mind go and be localized in the superior mediastinum. So, where is is the cardiac plexus? In which mediastinum? Easy. This is the first step in localization of the cardiac plexus. Any plexus, I have to localize it. Where is the brachial plexus? Between two muscles, scalene anterior and scalene medius. Where is the cardiac plexus? In the superior mediastinum, because it is fitting into the arch of the aorta, which is in the superior mediastinum. And I said in the lab, don't forget A, B, D. This here reminds us of the first lab, phrenic. And this nerve, you might see a glimpse of it. Vagus. One is anterior to the root or the hilum of the lung, and the other is behind. The vagus is behind, the phrenic is anterior. And again, the phrenic or the phrenic is going to convey somatic pain from parietal pericardium and parietal mediastinal pleura. Vagus is never going to mediate pain. Vagus is going for something, for me, is more important than pain. Starting by P, pressure. 24 hours. I'm standing like this, and vagus is supporting me by continuous reflex, helping the pressure to be stable. So, phrenic or phrenic is for somatic pain. Sympathetic for visceral pain from the heart, while vagus for pressure. So, when we speak about baroreceptor reflex, which one is mediated here?
Vagus.
Exactly. Vagus. Vagus. We finished localization of the cardiac plexus. A, B, D in the superior mediastinum. Contribution. The contributing filaments are sympathetic and parasympathetic because it's an autonomic plexus. As we said, I'm not going to the details of the sympathetic, how it is joining the system, but I'm going to the last part of this joining, which is the sympathetic system is two tubes from the base of the skull to the coccyx, parallel to the spinal cord. Instead of segments like the spinal cord, it is beads. In the cervical region, I have only 3 ganglia, even sometimes 2 ganglia. In the thoracic, I have 12. The heart will receive sympathetic filaments from 7 or 6 ganglia. If the 3 are there, 7. If only 2 are there, 6. How? 3 cervical and 4 upper thoracic. Vagus is also extending along the axis, the long axis of the body, from base of the skull to to the splenic flexure, not the coccyx. And I'm expecting from it filaments from the cervical and thoracic region. So, to recapitulate, the contribution or the contributing filaments, they are sympathetic and parasympathetic. Is there somatic?
No.
Did I mention somatic?
No.
No. What did we say about vagus? Is it going to mediate pressure?
Yes.
Is it going to mediate pain?
No.
Excellent. So if in the exam the baroreceptor reflex is mediated by phrenic, vagus, cardiac plexus, which one is the best? Plexus. Because vagus, it is vagus, yes, but the plexus is better. Because the plexus is having going and coming. Anyway, let's go, we'll see it nicely after that. So how many ganglia are there?
7 or 6.
7 or 6?
3 or 2 is
7 or
6.
from each of the cervical ganglia, I'll have one nerve. From each of the thoracic ganglia, when I say ganglia, does it mean sympathetic or parasympathetic? I will have plenty of nerves. Hundreds. Cervical, thoracic, sympathetic. Both of them should be distinguished from cervical and thoracic vagus. You agree? How can we distinguish? By changing names. Filaments coming from the sympathetic will be called nerves. From the parasympathetic will be called branch. As simple as that. Let's be simple and very simple. So I have cervical cardiac nerves and thoracic cardiac nerves. I have cervical cardiac branch and thoracic cardiac. Very good. Again, I have cervical cardiac nerves and and thoracic cardiac nerves. These are sympathetic. And I have cervical cardiac branch and I have thoracic cardiac branch. These are parasympathetic. If I have here 3, these are cervical cardiac, aren't they? Cervical cardiac nerves or branch? Nerves. So one is superior, cervical cardiac nerve. One is middle, cervical cardiac nerve. One is inferior, cervical cardiac nerve. You agree?
Yes.
The vagus 2, upper and lower, cervical cardiac branch. Very simple. Before I go, and I'm not going very much to tell you the truth. But before I go to next, please, keep this in mind. 2 points. The first point is, this is a car, and this is a car. As I said, my car in the garage is 0 speed. While here, when I have this car from Allah subhanahu wa ta'ala, He doesn't give it to me 0 speed. The car here, compared to this, Allah gave us a heart working at 160 or 170 beats per minute. goodness, very fast car. The car in the garage is 0 speed. In order to make this car in the garage work, I should put my foot on accelerator or brake.
Accelerate.
In the garage, the one in the garage is 0. Where should I put my foot, on the accelerator or brake?
Accelerator.
Accelerator. And for this car, which is 160,
Brake.
I have to use the brake. Are you following?
Yes.
The accelerator is sympathetic. The brake is
Parasympathetic.
parasympathetic. So our heart, is it on a sympathetic drive or parasympathetic drive?
Parasympathetic.
That's it. So which one is important in us? The parasympathetic or sympathetic?
Parasympathetic.
Parasympathetic. Are you following?
Yes.
I'll answer the question again in another way. And please, in another way. In another way, to answer this question, why is it more important? If I am going to receive my heart rate is 84 or 83 per minute regularly. If I'm going to give up my heart and receive another from whoever, is it going to be innervated or denervated?
Dinner.
Is it going to be innervated or denervated?
Dinner.
It is not attached to nerves.
Yes.
And it will beat at 110 per minute, not 84. This is what we find. Whenever we transplant heart, we put it always above 100. Yes.
Doctor, why 110 instead of 170 since there is no parasympathetic?
Excellent. Excellent question. 170 was when we were young. Very young. And then it dropped, and then the parasympathetic drive was over the 110. So we need the parasympathetic badly. This is why most of the plexus will be parasympathetic. If this is the plexus, and I irritate it like this, what do you think will happen? Is it more parasympathetic going to be irritated or sympathetic? Parasympathetic. And this, again, answer my question in a third way. When in Japan, they were working on a person removing the right lobe, the mid lobe of his right lung, all of a sudden, although cardiacally he is normal, his heart went to arrest. Why? Because we stimulated parasympathetic. Distribution and function. I want you to remember in function 2 C's and 2 B's, and already we discussed them. We discussed the pressure. Who is doing the pressure? Parasympathetic. Vagus. The pain. Sympathetic. Conduction and coron. This is easy. I'll solve it in one slide. In one slide, I'll solve it like playing chess. To start with, this is what? Arch, and this is what? Where is the cardiac plexus? Where?
Beneath.
Mediastinum. To complete the localization and make it in relation to ABD, look, it is like this. And now, look at this. ما تلاقوهاش في أي دي بس أيمن إلكترونيك خلاص؟ بقول لك روح على مش عارف الويب وطلع ويب ايه وبتاع ده انا اللي عملت الويب يا حبيبي
كبير
ده ايه ده So here how we see the relation, how we see in Canada they are asking me until now, please contribute to the 3D whatever فيكم سميت project أنا سايب أوكي الحمد لله ما شاء الله
كبير
شكرا
كبير جيش
اللي بيسجل يسجل مرتين
لا
شايفين بقى الريليشن شايفين الريليشن دي سهله ازاي وحلوه شايفين
حبيبي
so we have superficial part and we have deep part of course this is the superficial part you agree
yes
and the deep will be inferior and posterior or to the right of the aorta يعني ده ممكن اقول to the right ممكن اقول ده to the left of the aorta ممكن اقول ده anterior ممكن اقول ده posterior are you following
yes
so this is superficial part and the rest is deep part and the rest is deep part very good we have to remember that there is here one nerve running like this and another like this مين بقى اللي ورا فيجاس ولا فرينك واللي قدام I agree excellent so there is here فرينك قدام وهنا مين فيجاس you agree because phrenic is going to be anterior to the hilum and vagus will be posterior to the hilum خلي بالكم بقى فرينك يجي كده اسف فيجاس يجي كده ومن تحت يطلع حاجه اسمها recurrent laryngeal وفي هنا حته بقى حاجه كمان اسمها ductus arteriosus so this superficial part is it to the right or to the left of ductus arteriosus
To the right.
to the right very easy so easy ادي عندنا برضو plexus now ABD ABD is very easy now to look at this it's very easy to know we in this this is diagram of Netter one of the very good diagrams of Netter. Here you note part of the arch of the aorta to see the inferior part and the posterior part which are constituting the deep part of the plexus. This is the superficial. The most anterior is here. Here you can see by yourself that there is vagus and here is recurrent laryngeal. أنا بس مش شايف مين؟ الفرينك. I cannot see phrenic. Can you see it? No. لكن very nice. Here you can see D, which is division of the pulmonary, and here you can see B, bifurcation. You can see now that the plexus is superior to the division of the pulmonary. It is anterior to the bifurcation. It is inferior and posterior and anterior to the arch. When the Japanese were working in this area, they stimulated the deep part. They were removing here the middle part of the lung, or the mid-lobe. They stimulated the deep part, which is any part of the plexus is mostly parasympathetic. So the heart went into cardiac arrest.
Doctor? Okay. Is the superficial the same as interior?
Yes. Superficial is the same as anterior.
And the right, right? Left, right.
Superficial is the same as anterior. And it is left to the aorta. Here are ganglia, 7 ganglia, and vagus and vagus. Let's see more and more in the distribution. The only thing that we can make the distribution as easy as water, as we say in Arabic, is this. I repeat it again. Please look at it. Please look at it again. How can I name this? Is it left or right?
Left.
Left. Is it cervical or thoracic?
Cervical.
Okay. Is it cardiac or pulmonary?
Cardiac.
Excellent. Is it nerve or branch?
Nerve.
So it is left. Superior. Cervical. Cardiac. Nerve. Is it sympathetic or parasympathetic?
Sympathetic.
Going to superficial or deep?
Superficial.
You are excellent. We need the deep. Is this lower or upper? Lower. Is it cervical؟ هنا بقى الخط ما بين cervical و thoracic. Is it ده لابد ينزل شوية معلش. This should be cervical, okay? And it is cervical. Cardiac ولا pulmonary? Cardiac. Branch or nerve?
Branch.
Branch. These two are restricted totally, entirely to the sympathetic. To the sympathetic, to the superficial part of the cardiac process. The rest, any filament from here, from there, from here, from upper, will go to the deep. Are you following?
Yes.
So, in the exam, if we say the deep part of the plexus has fibers from the right upper cervical cardiac nerves, right or wrong? Right. If it is the left, wrong.
Wrong.
As easy as this. And we apply it to Vegas as well. What does the superficial part of the plexus supply? What does it do? To answer this, exactly, caliber, it controls the caliber of the right coronary. Look at this. Here is the right coronary. Here is the left. You can see how we are close, very, very close. So the left coronary is controlled by the deep. The SA node, which is conductivity, is controlled by the deep or superficial?
Deep.
The deep. Because the superficial is doing only caliber of the right coronary. So the SA node conductivity is controlled by the deep. The AV node by what?
Deep.
The deep, the conductivity. You agree?
Yes.
If I divide the deep part into right and left, the SA node will take from the right side or from the right, and the AV node from
Left.
And this what happened to the Japanese. While they are working on the right side, they hit the right side of the deep plexus, stopping the SA node. Why stopping the SA node? Because
Parasympathetic.
most of the plexus is
Parasympathetic.
parasympathetic. You see, it is some words and I'm playing with them to make it complex, but not with smart people like you. Impossible.
كبير.
I'm trying to make,
كبير.
not with you. You are very
With
smart.
Canada people.
You agree?
بالأخير.
Here a reflex. Here is a reflex to finish with this. And the reflex is, as you can see, here is carotid, and here should be the arch of the aorta. From both, we'll have sensation of the pressure. Is sensation of the pressure going through sympathetic?
Paras.
Parasympathetic. Okay? And as they say in neuro, from the carotid sinus, it is glossopharyngeal nerve, which is number 9. But in many of the new research as well, there is vagus in it. And here it is entirely vagus from the arch. Why entirely vagus from the arch? Because the plexus itself is there, under the arch. So here we have efferent or afferent?
Afferent.
Afferent of pressure. And now, here is efferent. And this efferent is going to what? SA node and AV node. Is it going to the deep or superficial part of the plexus?
Deep.
You are excellent. And this is sympathetic. If I have high blood pressure monitored here, is the sympathetic going to be inhibited or should be accelerated?
Inhibited.
Inhibited. In the heart and the skin, this is the base of the baroreceptor reflex. I started by this and I end by this. Phrenic, somatic, phorenic, well-defined pain, well-localized, well-described, the nature of it. Oh, it's biting, it's snapping, and referred to,
Shoulders, top of the shoulder.
while the other one we mentioned a point which I dropped, the pain which is visceral and carried by sympathetic only. It is mediated by the inferior cervical cardiac nerves. So the inferior cervical cardiac nerves, both of them are for carrying the visceral pain. And both of them are communicating with C8 and T1. The filaments are coming from C8 and T1. So if I have pain, which is ill-defined, ill-localized, it will be going to, or it will be referred to C8 and T1. And some people also add T2, T3, and T4. They said some of these also carry some pain. So if these are carrying 30%, this is carrying 70%. This is why in most people, the pain of myocardial infarction or ischemia is referred to the inside of the arm. So we know that this ganglion has nothing to do with anything but control of the caliber of the right coronary. You agree? You agree?
Yes.
And why is the right coronary between you and me? Because, as I said, the right coronary is the most important vessel. It has two nodal arteries, to the SA node and the AV node in most people. This is great. So we know this for this. We know this for what? Pain or pressure?
Pain.
These two, as I said it, and I'm ending at this with a small word of fun. It is the middle, and as I said, we remember it by saying the Middle East is always accelerating. So the middle cervical cardiac nerves are accelerators. We have always accelerating events in the Middle East. Thank you so much.